Good morning, everyone, and thank you for joining our webinar today. My name is Justin True, the Director of B2B Marketing at MDLIVE. With us today is our expert staff and colleagues, and we're here to discuss COVID-19 and how telemedicine has handled and is making an impact on a global crisis. Getting started right away, let's cover the agenda and a few basic housekeeping items. Today's webinar, we'll be hearing from our panel moderator, Michael Farrell. Michael is MDLIVE's Senior Vice President and General Manager, Hospitals and Health Systems. Michael will introduce our speakers, and then we'll cross topics ranging from a brief introduction to MDLIVE, COVID-19 updates and MDLIVE policy, legislative and regulatory perspective and updates, perspective from a health system, patient communications, and questions and answers. Please use the Q&A function within the GoToWebinar application that you'll find on the webinar toolbar. The tail end of this presentation will include a live Q&A with our speakers. Upon closing of the webinar, we will get to work quickly to make this recording available to you to view on demand and for you to share with others. Expect to receive an email from me within the next 48 hours. With that, I'll let Michael take it away.
Thank you, Justin, and thanks everybody again for joining our webinar today. We're grateful for your organization to take some time in the unparalleled environment that we're in today, and we believe that this information will be valuable to you, your consumers, your patients, and your organizations. We have a phenomenal panelist group today, led by Dr. Brian Treon, who is MDLIVE's Interim Chief Medical Officer. Like Justin talked about, we have a multitude of special guests that are going to be talking about their relative industries and expertise. Krista Droback is one of them. She is the Executive Director for the Alliance for Connected Care and is going to be talking to us today basically from an update from Washington, what's going on from a legislation perspective, where were we prior to COVID-19, what's being changed now in the future ahead. We're lucky enough to have Dr. Cindy Zellis, who is the Vice President of Ambulatory Operations and Telehealth Services for University Hospitals in Cleveland, discussing their organization as an integrative delivery network, how they have planned for COVID-19 and their preparation and future ongoing operational plans to deal with this crisis. Rounding off the panelists, we have Dave Bazinski, our Vice President of Brand and Digital Marketing at MDLIVE, to talk about the consumer, what's at the consumer forefront, how are we educating our consumers on what's going on in the industry, and tips and tricks for your organizations to leverage to continue to update and provide awareness to your consumers and patients. So thank you again to our panelists, and we look forward to the opportunity to take questions from the audience. Quickly about MDLIVE, if you're not familiar, MDLIVE is a leading virtual care company in the industry today. Our organization has been around since 2009. Currently, we have around 44 million Americans that have access to MDLIVE, either through health plan relationships or employer relationships. We also have about 40 health systems today that leverage the platform to provide virtual care to their consumers and their patients on a multitude of use cases. Something that MDLIVE is highly focused on and has been for quite some time is automation and optimization and throughput to provide the most efficient and convenient and highest quality impact to care that we possibly can. You see Sophie at the center of this slide. She's our AI assistant chatbot that assists with registration. Also, she runs the patient through an adaptive interview with branch tree logic and simple routing technology today. But most of our consumers, health plans, and health systems are continuing to leverage the technology put out by MDLIVE to take care of their patients and their consumers. The majority of our partners around the industry are leveraging our technology, like I said, in a multitude of use cases and fashions, whether that's for their consumers for medical, behavioral health, dermatology. Some of our health systems are leveraging it for multiple specialties such as endocrinology, oncology, and a multitude of others. It's a single platform that we've leveraged through an organically grown proprietary architecture that is leveraged today for all of our clients and partners around the US. So that's a quick 2-minute understanding of who MDLIVE is an organization. And now I want to turn the opportunity for our Interim Chief Medical Officer, Dr. Brian Treon, to take us through the MDLIVE updates on COVID-19, as well as any important talking points to our providers and how we're practicing from a policy perspective. So I'll turn it over to you, Dr. Treon.
All right, well, thank you, Michael. I hope you can hear me, and thank you to Justin for putting this together. We're hearing words like unprecedented, uncharted waters, uncertain times, and that's not hyperbole. That is the nation is being completely changed by this. So information is key. So thank you to all who put this together. Hope I get, there we go, the next slide. Just to kind of give us a touch point as to where we stand right now globally. 436,000 cases confirmed of COVID-19, resulting in quite nearly 20,000 deaths. That equates to a mortality rate of about 4.4% globally. In the United States, about 55,000 cases with 802 deaths. The good news is that our mortality rate seems to be at about 1.3%. That's the good news. The bad news is if you look at the numbers, the cases in the United States seem to be doubling about every 2 to 3 days. So certainly there is some prolific growth of COVID-19. There's been positive cases reported in all 50 states, Washington, D.C., and so it is everywhere in the United States. These numbers are updated. It says March 24th. Actually, they're updated since this morning, and undoubtedly it has changed since that time. As far as MDLIVE, we are seeing fielding questions. We're identifying patients under investigation. We can talk about that in a moment. But virtually every state, we're receiving telephone calls with concerns regarding COVID-19. The national government turned to telemedicine as the virtual first responder. We are truly in a battle against COVID-19. The problem that we're experiencing is it's a war against an unfamiliar enemy, and we're fighting with unconventional weapons. So what does that mean? It's an unfamiliar enemy. Take, for instance, influenza. It's a seasonal pattern. We've treated it in the past. Certainly there's variations from year to year, but we've got a basic understanding about how the disease is going to behave, and we can predict what's going to happen from flu season to flu season. With that said, in late December 2019, in Wuhan, China, patients began to be identified with viral pneumonia, and the etiologic agent was really not all that clear at the time. With some investigation, a novel coronavirus was identified, and it was named 2019 novel coronavirus, or 2019 nCoV. The emphasis is on the word novel. 2019 nCoV is the agent that is responsible for the disease COVID-19 or coronavirus disease. Novel, it is an agent that has caused a pandemic that is completely new and uncertain and has unknown behaviors. So we are treating it with unconventional weapons, and specifically pertaining to this telephone call is telemedicine. It's been tapped as the main entry point of patients with concerns for COVID-19 into the healthcare system, and it really makes perfect sense. Telemedicine is easily accessible via telephone call, via video chat. It keeps patients isolated at home while still receiving medical care. Patients are not required to go out and expose themselves to the petri dish of the emergency department waiting room, and conversely, they're not spreading their infectious disease process to others in society. So what COVID-19 has really done is transform telemedicine. Previously, it was a convenient way to practice medicine. Suddenly, it has become a safe and effective way to practice medicine. There have been many turning points across the United States as far as our history is concerned. We talk about pre-World War II, post-World War II, pre-9/11, post-9/11. I certainly believe that COVID-19 will be a new chapter in the history books, and that telemedicine will become integrated into the fabric of our culture. As far as response of MDLIVE, I'm not working the slides. Can someone move it forward for me, please? In response, MDLIVE created a policy to educate and guide our providers in the treatment of COVID-19 and relies heavily on information from the CDC. But to say the situation is fluid is really an understatement. And as a case in point, we're currently working on version number 7 of our COVID-19 policy. Further, the recommendations that the CDC had at the onset, which were rather concrete, have become a bit more less specific. And as a case in point, I touched on the item of a person under investigation. These are the needles in the haystack. These are the nuggets that we as the medical providers are looking for. Person under investigation, or a PUI for COVID-19, is really the targeted audience. At the onset, the CDC had very strict guidelines as far as what a PUI represented. Initially, it was a person who had lower respiratory tract infection signs, as well as either 1, travel to an endemic area of the globe, or 2, possible exposure known exposure to anyone with a positive COVID-19 test. So that was it. That's what a PUI was. Recently, there has been thrown in the wild card of high degree of clinical suspicion. So in other words, a physician is now able to use his subjective judgment rather than objective items. And so really now anyone with evidence of a cough, fever should at least have the consideration of being a PUI or being possibly having COVID-19. So moving forward, MDLIVE will continue to monitor the CDC recommendations. We will adjust our policies as appropriate, and we're learning as we go, as I think the remainder of the telemedicine field is. So I'll turn that back.
Thank you. Thank you for that update, Dr. Treon, and you're extremely right. Telemedicine is now at the forefront of everyone's mind. There are monumental changes from a government and state perspective coming down, and we're lucky enough to have Krista Droback here, again, who's the Executive Director for the Alliance for Connected Care, to give us an update on Washington. So Krista, I will turn it over to you.
Great, thanks. So I have 20 minutes, so I'm going to talk fast. I just want to give you a brief introduction to the Alliance for Connected Care and then talk about developments in telemedicine policy that have happened in the last month, actually like 2 weeks, but it feels like at least a month. So these are our members. This is our advisory board. You can find us online at www.connectwithcare.org. So we are an advocacy organization and have been really focused on what is happening on Capitol Hill and within the administration. So I'm just going to go through the various coverage programs, starting with Medicare. So the first supplemental, so there's been 2 supplementals, and then the third one, the language is almost final and will be voted on by the Senate today and likely pass the House tomorrow. It will just pass the House on UC because they can't bring their members back. So the first supplemental had a Medicare provision in it that lifted the originating site and rural restrictions. So for those of you who don't know Medicare well, essentially you could only practice telemedicine, get paid for it if the patient was in a rural area in a rural institution. So it had to be a doctor's office or hospital. So they waived those requirements, and so telemedicine could essentially be practiced throughout the country, and a patient could be in their home. The one limitation that they included in the supplemental was that the individual had to have at least a relationship with the provider sometime in the last 3 years. If that provider was not giving care, that had to be another provider who was in the same tax ID number. And the relationship had to be established through a Medicare claim. That language has been deleted in the third supplemental. So assuming that the supplemental passes, that language limitation will no longer exist. So essentially, there will be no relationship requirements, and providers can see new patients and seniors can go to new doctors. Okay, so CMS released guidance shortly after the first supplemental passed. They clarified that this telemedicine waiver applies to all diagnoses. So you can use telemedicine for any treatment of any kind of symptoms during the public health emergency. And it also clarified that you can use the phone as long as it's a smartphone. it has to be audio-visual. It has to be capable of audio-visual, so you can use the phone. They also waived HIPAA for telehealth platforms, so that means you could use FaceTime or Skype. And they also allowed for the waiver of copays, so you can choose to either waive the copays or the entire visit. Finally, the DEA waived prescribing regulations around controlled substances. So there's a law called the Ryan-Haight Act that prohibits prescribing of controlled substances over telehealth, and the DEA waived it for, I mean, essentially it's mainly for behavioral health prescriptions. I'm sorry, I'm trying to, oh, there we go. Okay, so that's Medicare fee-for-service. Actually, let me just say a couple other things about Medicare fee-for-service. So these are pre-COVID, but the administration has been putting a lot of emphasis on virtual check-ins. So these codes were approved for 2019, but again, the administration's putting a lot of emphasis on virtual check-ins. So in the code, 1834M, they define a telehealth service using actual codes. So these are the codes here you can see in red that are subject to rural and originating site restrictions. Well, CMS decided to interpret this as meaning that any codes outside of these codes within this parentheses are not subject to rural and originating site restrictions. So they made up some codes. And they made up a virtual check-in code, which is a 5 to 10 minute medical discussion. This code can only be used with established patients, and you cannot have seen the patient in the last 7 days or in the next 24 hours. So you can't really use it for triage, and you can't use it for follow-up, which we've always said was a major problem with this code. You essentially get paid $14 for using this check-in code. And what we've found so far is that most providers are saying it's not worth it because, you know, the compliance bar is so high to go find out if a patient has been seen in the last 7 days, and you can't use it for triage. So most folks are not using it, but you can use these store and forward codes. I mean, these store and forward codes are being used. And then the last thing is that there are codes for interprofessional consultations. So providers can get paid in Medicare for talking to each other, and the reimbursement is based on the number of minutes that you spend talking with each other. So I'm going to go back to Medicare Advantage. So that was Medicare fee-for-service. Medicare Advantage, CMS issued COVID guidance on Medicare Advantage, and most Medicare Advantage plans have taken advantage of this and are either waiving completely or reducing enrollee cost sharing around telemedicine, and they are taking another look at the kinds of Part B services that they reimburse via telehealth. I've been really impressed with the health plan's response to telehealth in the COVID crisis, so they are doing a lot more in this area. If you want to look at any of this guidance, it's on our website, by the way, the full guidance. Okay, on to Medicaid. So CMS issued guidance to Medicaid to states, and unfortunately, there is no authority at the federal level to waive state licensure requirements, but they can waive payment. So they did waive payment across state lines. So that means if you're a doctor in Illinois, you want to treat a patient in Indiana, you can get paid by Medicaid and Medicare for treating that patient. However, it's still up to the state to waive the licensure requirements that would permit you to treat that patient. CMS has also basically lightened the regulatory load on trying to change your Medicaid policies, so states can change their Medicaid policies relatively quickly. Most states have not replicated the rural requirements, but many states have replicated the originating site requirements for telehealth. So these are the states here in orange where patients cannot receive telemedicine in their homes and have the provider get reimbursed. So some states are taking action and waiving originating site restrictions during this COVID crisis, but it does add a layer of complexity to figuring out where you can practice and where you can get paid. On the commercial market side, there is a HSA provision in this third COVID supplemental. So right now there are more than 30 million people in the U.S., mostly in the large group market, that have a high deductible plan coupled with an HSA, a health savings account. The IRS code prohibits people with an HSA from receiving free or discounted telemedicine services. So there are employers that provide, or employers or health plans that provide a discounted telemedicine benefit, but HSA holders cannot use it until they've met their full deductible. And as you can see here, deductibles can be up to $3,000, almost $3,000 for a family. So that has prevented a lot of people with HSAs from using telemedicine. The bill that it will hopefully pass the Senate today and the House tomorrow does create a safe harbor through next year. So people with HSAs will be able to receive free or discounted telemedicine services through their employer or their health plan. And this is kind of complex, so I won't go into it because I have 10 minutes left. So other changes that are in this third supplemental, they waived the requirement for face-to-face visits with for home dialysis patients. So dialysis patients can visit with a nephrologist from their home. They have waived, you can use now telehealth to conduct a face-to-face encounter for recertification of hospice. And they are encouraging the use of telecommunications for home health services. So the secretary could now consider ways to encourage home health services to use telemedicine. They also put $29 million into the telehealth network and telehealth resource centers. I'm sure you're all familiar. There are some really great resources that are at the regional level on telehealth, and their federal government is now putting even more resources into those groups. And then we already talked about the home health. Okay, so as you all know, most states have declared a state of emergency, and this allows quite a few options, including waiving state licensure laws and waiving the physician-patient relationship. You can also waive the originating site requirements that we talked about in Medicaid, and then, of course, co-pays and other treatments. And then the federal declaration of emergency opened up another whole series of opportunities for the Trump administration to waive federal rules. But once again, there is no authority to waive licensing laws at the state level, but they are doing things like what we already talked about, waiving HIPAA, waiving the DEA rules, that kind of thing. So on the state licensure laws, as you all know, there isn't much portability of license across state lines, and again, the states have to do it. So states are waiving, as of today, 33 states have waived their licensure laws. Here's some examples. I believe we have a chart that we're keeping updated on our website, but as of today, these are the states that have waived licensure, and again, they have to do it for the different medical specialties because the physician board oversees physicians and physician's assistants, but each state has their own nursing board. They have their own pharmacy board. So each of the boards have to, work with the governor's office on all of those waivers. This is something that we've been particularly interested in, EMAC, the Emergency Management Assistance Compact. This is a nationwide compact that triggers in case of emergency, where governors can have other medical professionals and just generally professionals come over state lines and help. So we would like to see the EMAC triggered for state licensure. It would create a much easier to understand system of waivers, and also it creates indemnity for the providers that would be crossing state lines. So if you don't have an enterprise malpractice contract, you can be indemnified essentially for practicing across state lines. So the National Governors Association released guidance this morning and also 2 days ago talking about EMAC. And then the EMAC Association is also, it's called NEMA. They're discussing with their members triggering EMAC for state licensing. These are, again, some resources. These are actually links. So I should have put the actual link in here, but there are resources on all of this, on each of these. And the Kaiser Family Foundation actually has a state-by-state tracker that is an interactive tracker that has a lot of really good information on it. Last, I'll just tell you really quickly, before all this happened, we were getting pretty close on a bill to permanently waive telebehavioral health restrictions so that people can receive behavioral health and substance abuse treatment over telemedicine. I think that this will be sort of the first thing up after the COVID crisis is declared over. So for those of you who are interested in telebehavioral health, we're hoping that we can get that done for seniors, I guess now, probably next year. I think that might be it. I think that's it. Turning it back to you.
Unbelievable. Thank you so much, Krista. Just to reiterate, you said on your website, is there a list of the state updates by state? I know you have it in the slide, but is there an option on your website?
Yeah, the chart. Yeah, the chart is on our website. It's connectwithcare.org.
That's great. Thank you so much. And we appreciate your time. Hopefully there'll probably be a few questions for you at the end. So thanks again. Dr. Zealous, thanks so much for agreeing to be on our webinar today. We'd love the opportunity to hear about what University Hospitals is doing in Cleveland from a health system perspective and how you guys are planning for the future. So Dr. Zealous, I'll kick it over to you.
Sure, thanks, Michael. And from all the panelists prior to, I mean, certainly it's an unprecedented time, and what we've seen from a health system frame is the speed to adoption, acceptance, and the desire for telemedicine to really help continue to serve our patients. This is truly going to transform and elevate telemedicine as it stands. And I'll take you on a journey that we're having currently at UH. So first and foremost, I think what's important, we have a very strong structure across dealing with a COVID crisis of a full incident command structure. And I would call out that, you know, telehealth is actually a key pillar that is reported and talked through on our fullest evidence or our fullest level of our incident command structure. And so we are leveraging it across, and I would say serving our patients. And I think it's very important as we think about this, that we've been thinking about our patients in kind of 4 buckets. When we say serving our patients, we certainly are, how do we use telemedicine to serve our COVID patients that are currently ill and or need screened? 2, how do we use telemedicine to help what I would call COVID avoidance for both patients and providers so that they can continue to get care? Number 3, how can we continue a level of patients who just need healthcare business as usual via telemedicine on aspects, because certainly conditions such as diabetes, abdominal pain, those things will continue on, and so how we're leveraging telehealth that way. And the 4th area of patients is to be prepared on the future surge that we will see, whether it is the surge related to increased COVID needs from the actual condition itself, but also that post-surge of people who have delayed their care. And so this foundational structure of telemedicine that's going into place across all our infrastructure will hopefully will be able to serve our patients across those 4 buckets of patients. Again, COVID treatment, patient and provider avoidance and care, business as usual, and then the future surge of patients. So at UH, what we have done is we do have a core team that I'll share kind of the cross-reference, and we are launching very rapid and acceleration, primarily in our partnership with MDLIVE, both our UH virtual visit, which is our virtual urgent care platform, our UH virtual office, which is for our specialists in primary care, both synchronous and areas of asynchronous. We are using inpatient telehealth for not only consultation, but direct care by patients for nurses and providers, as well as family and patient engagement, as well as inter-hospital collaboration. We have 16 hospitals, and certainly the resources to be able to spread in this area, as well as to conserve our PPE and personal protective equipment is critical. And telemedicine not only helps continue to serve our patients and protect our providers and patients, but it also allows us to, conserve PPE. The fourth area is obviously in our emergency department, how we're leveraging telehealth before they actually enter the emergency room. The fifth is we're leveraging telemedicine for a speed up process in our COVID-19 drive-through on communication back to our central command. And then finally, leveraging another platform for AI consumer COVID-19 education. So you can see the adoption is quick, and all those providers, administrators, even patients who have had fear and trepidation of telehealth, they're seeing the opportunity across multiple areas. Speed of delivery is critical, and certainly we are now working on aspects of leveraging MDLIVE, but we are also, in the short-term continuing work across other platforms as the regulations have decreased. However, one of the things to keep in mind as people rapidly advance telehealth, and we're keeping this clear, is what is your North Star for telehealth delivery. And while everyone is in kind of a rampant flux to ramp up telemedicine, how are you at the end of the day going to bring things back into some level of closure on aspects of a defined process for our health system, and also be able to, when the regulations hopefully continue to advance, we can continue to serve this as a springboard for more telemedicine. As I mentioned, we have a really significant task force that again is on our whole incident command structure. It is IT, our physician organization, telehealth at our core, project management, physician leadership, and multiple executive sponsorship. Locally, some of the things that we've been able to pivot in trying to relieve our pressure is, and Krista commented on this earlier, we were able to, because internally we have both a high deductible plan with an HSA and a traditional plan, we have been able to leverage the legislation change, and we have now rapidly moved to a $0 copay. We are looking on that virtual visit or virtual urgent care of increasing the number of providers so that, one, we can serve our patients, but two, also support the national telehealth need. Additionally, not commented on here, in working with our team and Dr. Treon's team, is providing an easy way for virtual urgent cares and those who've had concerns in a telemedicine encounter, an easy way to reach UH to determine whether or not they need COVID testing, and to be able to, in this market, be able to take care of those patients at the right level of care. We have designed advanced provider training and patient engagement, and most of all, the rapid adoption in our hospitals, as mentioned earlier, for PPE. One of the things that I think, going back to the patient and where telemedicine is just so critical, we talk about all these multiple systems and multiple platforms and taking care of multiple patients, but I'd like to take it back to a single patient. Telemedicine last night was able to be launched up for a single patient who was near the end of their life. I do not believe it was with COVID-19, but the family, because of visitor policies, had been restricted, and through the ability through telemedicine platform was able to share that moment and that last dying breath with their family together. And so I think as we think about telemedicine and how it's impacting the masses, we never want to forget that one patient that we're impacting every single time. And so I'm just always reflect on those single moments to never forget the individual patients. So thank you for the time. Again, telemedicine here is ramping up quicker than we can imagine and pivoting just as rapidly as I know the COVID guidelines are, and appreciate everyone's support and leadership, and happy to take any questions later or speak with other health systems offline.
Thank you so much, Dr. Zelas. And greatly appreciate you bringing in that story. At the end of the day, what we're doing here together collectively as an industry is helping out in so many different ways. And that story just, it puts it in perspective, the value that we're bringing to individuals all across the country. So thanks again. And thanks again for UH and everything you guys are doing to help out everyone all over the state of Cleveland. All right, let's turn it over to Dave Zazinski on our marketing team, who's our Vice President of Brand and Digital. He's going to talk through patient communications and awareness and tips for your organization to continue to keep your consumers and patients up to date on everything going on with COVID and the pandemic. So Dave, I'll turn it over to you, sir.
Great, thanks, Michael. Appreciate the intro and good morning, everybody. In the next few minutes, I'll walk through how MDLIVE is pivoting our communications and marketing strategy really to better address this crisis with our patients. The thing that hasn't changed is really a focus on our core customer and our core patient. At the end of the day, demographically, that individual tends to be 25 to 50 years old. They often have children in the household and are particularly time-starved, so place a real premium on convenient solutions like telemedicine. Now, what has changed for this individual, as we can all relate to, is their lived experience. And this slide tries to outline just a few of those major changes, right? We think about the pandemic stress, so the stress related directly to this disease and the medical side. So trying to understand who's at risk, what precautions should I be taking, and what information is out there that I can trust, and what should I be skeptical of. On the financial stress side, I think tomorrow there's an expectation that new jobless claim numbers come out, and it'll be one of the sharpest increases in the history of the country in terms of jobless claims. So clearly a lot of financial stress happening out there today too. The third element, family stress. With millions of Americans now ordered to stay at home, parents are really trying to figure out how to strike the right balance between work commitments, childcare, and education. There's a lot of new routines that families are taking on across the country. And the last item here is new ways of connecting, or really accelerating digital ways of connecting that we've probably seen, the home editions of late night shows like we have pictured there, but also just an increased utilization of things like FaceTime, Zoom, Google Hangouts for connecting with either school teachers, friends, or loved ones. So a lot changing about the customer's experience and the patient's experience in day-to-day life, but we're still maintaining a primary focus on those customers that are core to the MDLIVE telemedicine business. As we think about what this means for MDLIVE and our strategy, it's important to note kind of where we're coming from. And historically, we focused a lot of our patient communications and marketing strategy on patient acquisition. The majority of our investment has been there in the past, and it's really where a lot of our time and energy has been. But as you can see from this slide, on the left-hand side here, this shows site traffic to mdlive.com. Unfortunately, COVID-19 and the news coverage has been doing the acquisition for us at this time, right? As we see site traffic up almost 3x compared to what we would normally see this time of year. As you look at the data on Google search volume, searches for online doctors and telehealth is up about 2x versus where it was just a month ago. So this has really caused us to pivot our strategy as we're ramping up our provider network to take care of all of this additional demand. We're shifting from an acquisition strategy to these three pillars of our communication during the COVID pandemic. So number one, informing and empowering our patients. Number two is setting the right expectations with patients ahead of a virtual visit. And number three is starting to establish those new relationships. So we'll dive into each of these just a little bit more on the next slide. Here we go. So I think what's important to note is that the thing that doesn't change is at the top there, right? The MDLIVE brand and our target customer. I imagine for most on the phone, these things will be consistent as well for your organizations over time. But what we focused on are these three pillars again. So for inform and empower, the focus there is amplifying guidance from authoritative sources like the CDC and from our MDLIVE physician leadership team. There's a real role to play there to simplify some of that guidance and make sure that quality, reliable, up-to-date information is making its way out to our patients. We're also reinforcing the role of MDLIVE in telehealth with our patients as well. And we see that similar to what Cindy was mentioning, it's kind of three buckets. The first is assessing the COVID-19 risk for individual patients who think they might be symptomatic or have risk of COVID-19. Our doctors can address that customer or that patient and lead them to the appropriate next steps for care. The other is kind of business as usual, as we've listed as number 2 here. So avoiding the in-person care setting, business as usual, our doctors can take care of 80+ common conditions. So now more than ever, it's important to keep those individuals out of physical care settings. And the last one we haven't touched on much yet today, but it's really about helping to manage the anxiety and stress that's associated with this pandemic. We talked on the first slide about those 3 sources of stress that families across the country are dealing with now, and behavioral health through telemedicine is a great solution for individuals struggling with those stresses today. So that's inform and empower. The second bucket and second pillar is really about setting the right expectations. And here, what I think is important is that it's not just a marketing effort, right? It's a product, marketing, clinician effort to set the right expectations from an end-to-end consumer experience perspective. A couple of the key things that we've been managing expectations around are callback times. Across all of telehealth, wait times have been significantly higher than usual, so we're making sure to communicate those wait times to patients in advance to set the appropriate expectations. COVID-19 testing is another critical thing to set the right expectations around. As of right now, we aren't ordering, our doctors are not ordering COVID-19 tests. I know we're working diligently on potential solutions there. And then the last element is temporary policy changes. So for example, allowing now 90-day prescription refills on a temporary basis, whereas previously we were focused on shorter term refills. The last pillar is establishing new relationships. And this is very much work in process for us as well. But as we think about moving past this pandemic, there will have been a lot of new customers and new patients that have come to us during this really extraordinary time. So we need to think differently about how we nurture that relationship and continue to build that relationship between them and MDLIVE. And this next slide just shows how all of those 3 communication pillars are coming to life for our patients across channels in a way that really supports the brand. So the first, updates to our product experience online, and importantly, our call center as well. So that our call center agents are well equipped to handle any questions that come in around coronavirus. Number 2 is our site experience. As I mentioned earlier, we're up almost 3x compared to the site traffic that we normally see, and our coronavirus resource pages are incredibly popular right now. So we're keeping those up to date with the latest information, as I'm sure many of you are as well. Email, no surprise here, we continue to lean on email as an important channel for communicating with our patients. What I will say here is that our open rates and email engagement is up, almost 2x compared to what we would normally see. So it just underscores the importance of communications of credible information and clinical guidelines from credible organizations like yours and MDLIVE. And the last bucket is social as well. So at this stage, we're mostly focused on owned social advertising as we've scaled back some of our investments on acquisition marketing. But it's another important channel for us to get key messages around particularly informing, empowering, and setting expectations with our customers. On this next slide, just wanted to reinforce that for those of you that are clients today, we have assets available on the MDLIVE Engagement Hub. Right now, email templates and flyers about how best to leverage telemedicine in the case of the COVID-19 pandemic. Additional assets will be coming regularly every week. Check back in for the latest information. We'll be sure to keep those updated. It's really an important time, as all of you can imagine, to be communicating that reliable information to patients right now. And again, things like email, website updates are seeing tons of engagement from patients that have a lot of interest in information and incredible information about the pandemic. So to close this section, I'd say there are just 4 key takeaways for us that I'll remind you about. If we can advance the slide here. There we go. So the first is starting with what hasn't changed. Typically, that's going to be the target patient and the brand. At least in MDLIVE's case, we haven't changed those things in a meaningful way. Of course, we service all patients, but we really think about our communications focusing on a 25 to 50-year-old segment first. Then make the appropriate adjustments to your strategy and your communications for this moment. For MDLIVE, that meant a shift from acquisition to these 3 pillars: informing and empowering, setting the right expectations ahead of a visit, and starting to establish those new patient relationships. Number 3, I think previous panelists have mentioned this one, but it's incredibly important, that daily coordination across functions to make sure we're getting the right, accurate, latest communications out to clients and patients. So clinical, product, IT, marketing teams, all coming together to deliver the right communications and the right customer experience. And finally, don't forget that the communication assets are available on the MDLIVE engagement hub for all of our clients. So with that, I think that wraps up this section.
Thank you, Dave. Greatly appreciate the information. And thank you again, everybody, for attending this webinar. We have about 13 minutes and we're going to open it up for a Q&A for all the panelists. Again, you can type in your question into the tool, the GoToWebinar tool, and we will read the question out to the panelists. Again, this is being recorded and all information will be sent out via email from Justin. So that was one of the questions. You guys will get a copy of these slides. Someone asked for a copy of our policy. Again, when Justin sends out the email, please let him know if you're one of the individuals that have requested that, and Justin will get you in touch with your account management team to take the next steps on that. Krista, looks like you have 2 questions. One is regarding, could you repeat the information regarding relaxing HIPAA laws and regulations? And then the other one was around, what do you consider the future to be like once COVID is over regarding all of these reimbursement changes for telehealth, and do you consider that staying? So if you could answer the HIPAA question and restating that, and then what are your thoughts around the future for telehealth and reimbursement and everything that's changed in the interim?
The HIPAA waiver was necessary for the platform issue that people want to use FaceTime and Skype, which are not HIPAA compliant platforms. So they just waived that piece of it so that, again, so that, you know, lower tech communications can happen between doctors and patients.
Great.
I think that this, I think that there's going to be a major transformation for telehealth over the long term. One of our biggest challenges has been patients, that sort of hurdle of getting patients to try it. And so now I think that patients tried it after all of this, and probably if is consistent with the past, they've had a high satisfaction. We create a new constituency for telehealth. So to me, it feels like it helps us, at least on the Medicare side, lobby Congress to say seniors want this, and it helps us on the state side to lobby medical boards to say we need to make it more available to everyone.
Absolutely. I wholeheartedly agree. So thank you for answering those. Another question was around testing sites. So Dave showed you a few screenshots of our COVID-19 page that you can get to from going to MDLIVE.com. On that page, if you scroll down to the middle, our team has done a great job of putting together a list of testing sites around the country. You could filter by state. Again, that's information that we regularly update based upon our health systems or other partners around the country, letting us know that they have these testing sites available. So it's not an exclusive list of every test site in America, but it's all the ones that we know about, and we're trying to update that regularly for our clients and partners. So that is on the site. Dr. Treon, it looks like a question from you or clarification came about if a patient is identified as needing a COVID test, how are we providing guidance and next steps, where to go for testing, who performs the test, blah, blah, blah. So I can help you with that. I mean, MDLIVE is not ordering tests today, but we are informing clients around you know, what they have and trying to do a good job of treating that. But I'll let you answer that question if you can take that, please.
Absolutely, yeah. So ordering tests is a hurdle that we need to overcome. At the outset, telemedicine was for acute episodic care. In other words, I need to talk to a doctor for about 10 minutes and that should take care of things. There may or may not be a prescription thereafter. An attractive model for the patient, attractive model for the physician as well. I've got some free time. I can, on the spur of a moment, log on to MDLIVE and turn out a few patients. So it's a nice way to deliver medicine. In that model, it becomes difficult to order a test. Ordering is not the hard part, it's the following up on it. If a physician orders a test, he is responsible for following up on the results and getting the notification back to the patient. So if I'm the physician that's at home and I've got a free time and I'm going to take up a patient, I'm not necessarily committing myself to tomorrow signing on, following up on labs. So it's something that we need to do better on, and we are working through it. We're working through a process where MDLIVE physicians can order a COVID test and then through back channel means follow up on those results and notify the patient. As it stands right now, we're referring patients to their local resources. As a national company, we don't know what's available in your hometown USA. And we're finding that those resources are highly variable from public health departments who are absolutely on it to those health departments who are completely overwhelmed. To help combat that, we are developing a list, and I think Michael alluded to this, of testing sites where we can say, for instance, you live in your hometown USA. Here, I'm looking at my resource here, and I see that there's a testing site available on Main Street. There are those testing sites that do not require a physician order to perform. So there are hurdles to overcome, and we're working through it.
Great, thank you so much, Dr. Treon. Another question that came in was around wait times. Yes, I mean, we have mobilized teams, task force. The company is focusing on wait times holistically across the board. I could take this question. Basically asking, what are you doing for wait times? Are you tracking, PUIs or COVID positive patients in different parts of the country? And what are you doing besides being able to have your providers see patients from multiple states with the new requirements that are put in place? So I'll take that one for the team. I mean, like I said, this is a daily by-minute dashboard. The entire executive team is working on this. We really have a three-pronged approach. It's based around provider recruitment, providers incentives and engagements, and then consumer experience and access through the technology. So really on the first part, provider recruitment, I mean, we're hiring provider ambassadors, recruitment staff. We've done that for the last couple of months, as well as more individuals for our credentialing process to bring providers along much faster and at a rapid pace. We've added over 100 doctors to our network over the last 30 days. We've done a much better job over the last 45 days of engaging all of our locum providers, and we've seen about a 54% increase in capacity just from our locum providers. And then our teams are also out creating new relationships with organizations and provider groups around the country. I mean, everyone is in the same boat here. Realistically, it's a global pandemic, and this is industry-wide, really, from across the industry. But we're doing everything we can on the provider recruitment front. From an incentive perspective, we're paying the highest incentives that we've ever paid in our company's history right now to ensure that we have doctors and providers on the network, seeing your patients day in and day out. We do know wait times are higher than normal, and again, that's across the board, and we're doing everything we can to keep those down. And really, the third point is on the technology improvements. So we're working with our product and technology teams to provide more information up front, to create new rules and algorithms in our IVRs as information in our technology to help streamline patients, to bring them to be able to talk to someone sooner rather than waiting on the line for a provider, or giving them more visibility to the information that they're seeking. We're bringing in nurse lines and nursing staff around the country as well to be able to help triage. So it's really those three items that we're working on, and I think we're doing a great job trying to keep up to date and make sure our clients and all of your consumers and patients around the country have a positive experience. I'm going to take a breath there because that was a lot, but another question was around, let me read this. It was around MDLIVE infrastructure and technology. Is it holding up with surge? I'm knocking on wood right now. Yes, it is. Our technology teams, again, are at the forefront, working with Microsoft Azure, who is our SaaS platform backend, to ensure that we have the capacity and the bandwidth for all of our users and clients to be able to access the system with the expected turnaround times, from a technology perspective as normal. Right now, again, I'm knocking on wood, we haven't seen any hiccups, but our teams are on that. Again, have a by-minute dashboard of the technology, the infrastructure, the bandwidth, everything that we're providing from a technology perspective to make sure that we meet your needs. Let me go through Dr. Zealous. There was a question similar to Krista's regarding health systems, but how do you anticipate telehealth changing from a health system perspective after COVID-19, and what changes are your organization making to prepare for more telehealth in the future? You want to give us your thoughts on that, maybe?
Sure. One of the things is certainly the core governance and an infrastructure to support. This is speaking to the point of all hands on deck. So I think there is definitely where telehealth might have been an afterthought, how this truly needs to have infrastructure and greater resources is one. Two, I think while it has been important for the speed to delivery, that there has been kind of an expansion of multiple platforms, that's non-sustainable in a non-COVID kind of crisis pandemic. And I think maintaining kind of streamlined processes of regular or single platforms will be critical. This is why, as we've been working personally with MDLIVE, as we've been launching our MDLIVE office, while we have been launching multiple platforms, we are working coherently that at the end of the day, we will all end up on the MDLIVE office platform, because that's the way to ensure streamlined processes. We can control things when regulations may or may not change. We can monitor quality. So while it's a little bit rogue, we're trying to keep the pieces in place so that after this, there is a solid infrastructure moving forward to maintain the momentum, the volume, and the real transformational change.
That's phenomenal. Thank you again, Dr. Zealous. Last update is my marketing team is letting me know the testing site on our webpage we are taking down right now, and we're replacing it with how to find a testing site, as well as watch outs for testing site information to make it more readily available and streamlined for our clients. So just want you to note that is a change that I'm learning about as we go along. So again, we're rapidly changing and moving to accommodate our clients and our partners around the U.S. Thank you all for joining this webinar. We hope you thought it was valuable information regarding COVID-19. Again, watch out for an email from Justin True with the recording and the slides and any information that your organization needs. He'll put us in touch, the client teams, with our partners. So again, thank you all for your time. Stay safe, keep your families safe, and hope you have a great rest of the week. Thanks, Justin.